So good afternoon, everyone. Welcome to Neurology Grand Rounds, and it's my pleasure to introduce Michelle Kim, who's going to speak to us today. Michelle is a Washington native and got her undergraduate degree in psychology here at the University of Washington. And after she finished that, she went to the Fuller Graduate School of Psychology in Pasadena. I'd never heard of this place, but she got her MA there in clinical psychology, then finished her Ph.D. in clinical psychology. Before doing a postdoc at Harvard in adult clinical neuropsychology, and has been here at the University of Washington, the Regional Epilepsy Center, since 2014. She has several professional society affiliations and has published quite a bit on the neuropsychology of HIV infection, traumatic brain injury, and more recently has gotten interested in epilepsy, which she's going to talk to us about today. I just saw they have a recent paper on the influence of interictal discharges on neuropsychological test results and surgical planning, which sounds like an interesting study that I'll look forward to reading. So, Michelle, thank you for speaking to us.
All right. I know that I speak quietly, so if you can't hear me, just let me know. And so today we're going to talk about selective laser ablations of the amygdala and hippocampus, and some preliminary data that we have. All right, and so in terms of disclosure information, I really don't have much to disclose other than the fact that I do receive research support from an NIH grant that was awarded to Daniel Drain at Emory University. In terms of learning objectives for today, so we're going to start off by talking about some of the standard surgical procedures that are utilized to treat intractable temporal lobe epilepsy and some of the clinical outcomes data that's available. We'll also talk about selective laser ablations and the preliminary data that we have and how that compares to the standard surgical procedures. And then we'll also discuss what this means for us clinically.
Can you pull the microphone down a little bit?
Yes, sorry. Is that better? Probably not. It's on. I'm sorry. I will try to speak more loudly.
That works right there.
Okay, good. All right. So in terms of statistics for epilepsy, epilepsy accounts for 1% of the global burden of disease. That's equivalent to approximately 65 million individuals worldwide with epilepsy, and it's estimated that a little over 2 million individuals live in the United States with epilepsy. And of the individuals that do have epilepsy, it's estimated that approximately a third of these individuals are actually uncontrolled or drug resistant. And temporal lobe epilepsy is the most common cause of drug resistant seizures. So an anterior temporal lobectomy is a pretty standard procedure for treating drug-resistant temporal lobe epilepsy, and this involves the resection of the anterior lateral temporal portion followed by a resection of the mesial structures, including a portion of the hippocampus and then the amygdala as well. In terms of seizure outcome data, so the data is actually a little bit scattered, but there is this longitudinal study put out by McIntosh in 2004, and it looked at 325 patients who had temporal lobe epilepsy and underwent an anterior temporal lobectomy. At year 1 post-resection, 61% of these individuals were seizure-free. At 5 years, approximately 48% were seizure-free, and then at 10 years, 41% were seizure-free. When they looked at a subset of these individuals that actually had hippocampal sclerosis that was identified on neuroimaging, the percentages went up slightly. So at year 1, it was 68%, 5 years, it was 54%, and then at 10 years, it was 47%. There aren't too many randomized controlled trials, but one put out by Weeb et al. In 2001, looking at anterior temporal lobectomy versus continuing patients on medications that were patients that were drug resistant, found that at year 1, postoperatively, 58% of these patients were seizure free, but a year out, the patients who were kept on just purely medication, only 8% were seizure-free. So this really suggests that an anterior temporal lobectomy is a superior approach to treating drug-resistant epilepsies, though the authors did suggest that you really do have to think about the cognitive impact of an anterior temporal lobectomy when you consider this as a treatment procedure. In terms of perioperative complications, so large case studies often don't report surgical complications that occur or provide very little detail of what occurs. But in 1990, NIH did put out a consensus report that suggested the combined morbidity and mortality was less than 5%. There was a population study put out in 2013 that actually looked at 736 patients who had temporal lobe epilepsy that ended up getting a resection, and these patients had their resections between 1988 and about 2003. And from that group, there was about 8% morbidity and 0% mortality. In terms of the few randomized controlled trials that were available to review, these did actually provide more details of the different types of surgical complications that occur as a result of an anterior temporal lobectomy. One study found that 4 out of their 40 patients, so approximately 10%, ended up having some sort of surgical complication. You can see that on the screen. And then another study found that approximately 33% of their patients ended up having some sort of surgical complication, though you can see that the sample size in that was a little bit smaller. In terms of cognitive outcomes, so a lot of the research focuses on individuals who are left language dominant, so their language is lateralized to the left hemisphere. And when they looked at patients who ended up having a left temporal lobectomy, they found that there were declines in terms of verbal memory as well as word finding and naming. And this is pretty well established in the literature. In terms of patients who ended up having a right anterior temporal lobectomy, the research is a little bit variable. So some of the research suggests that patients will have a decline in nonverbal memory, whereas some research actually suggests that post-surgically their cognition is relatively stable, or they may even have mild improvements, presumably because they are seizure-free. There have been some new developments in terms of how language is affected by an anterior temporal lobectomy, and that was put out by Dr. Drain from Emory in 2008. And that study found that following a left resection, patients were more likely to have extensive category-related naming deficits. And in terms of categories, it was specific to famous faces and animals in terms of the tests that they administered. Following a right resection, patients ended up having more category-specific recognition deficits. And this may be a new finding purely because these are not measures that are typically administered in terms of a standard neuropsychological battery. So this is just kind of an example of the types of errors that patients are making. So following a right anterior temporal lobectomy, patients will have these recognition errors. So they may look at that picture of Bill Cosby up there and say, oh, that's OJ. He killed his wife and got away with it. He was a sports star a long time ago. I think he played football. And so clearly misrecognizing him, whereas they may have been able to do so prior to the surgical procedure. Patients who ended up getting a left anterior temporal lobectomy may look at these pictures and correctly recognize the person. So, for example, looking at Angela Lansbury and saying she's an actress, she had a TV show, and it was called Murder, She Wrote. So really correctly recognizing the individual, but having difficulty coming up with their name. So these are the different types of newer deficits that were discovered. The selective amygdalohippocampectomy is another approach that is utilized for treatment in drug-resistant temporal lobe epilepsy, and this revolves the removal of the amygdala and hippocampus via either a transsylvian, a lateral temporal, or a subtemporal approach, and they do this in order to try and spare the temporal neocortex and white matter, though you can't damage to some of those areas is not completely avoidable. And so in terms of seizure outcomes, a lot of the studies that are available suggest roughly similar efficacy for an anterior temporal lobectomy versus a selective approach, while other studies actually suggest that an anterior temporal lobectomy may have modestly better seizure outcomes. So for example, Bate et al. In 2007 looked at seizure freedom rates 1 year postoperatively and found that those who underwent an anterior temporal lobe resection were 66% seizure-free at 1 year, and those who had underwent a selective approach were 44% seizure-free. Another study put out by McKinsey et al. In 1997 found that 60% of the anterior temporal lobectomy cases were seizure-free at 1 year, whereas only 21% were seizure-free of the individuals who underwent a selective approach. And some of the discrepancy between the percentages of seizure freedom in terms of the selective approaches may be due to the fact that, again, there are different types of selective approaches that are utilized. And so it makes comparisons a little bit difficult from study to study. A meta-analysis performed by Josephson et al. In 2013 actually found that 13 out of 15 studies comparing the two surgical procedures found that the anterior temporal lobectomy did end up having better seizure outcomes, and the risk ratio was equal to 1.32, which suggested that for every 13 surgical procedures done with each of the different procedures, that one more individual was seizure-free following an anterior temporal lobe resection. And randomized studies would be hard to do with this, and so really it's difficult to definitively compare the seizure outcome rates. In terms of cognitive outcomes, so the rationale for really using a selective approach would be that if you're reducing temporal damage, that you're going to have improvement in cognitive outcomes, but this is kind of difficult to examine because, again, the selective approaches vary from study to study and even sometimes within study. And then the way that cognition is assessed can vary as well. So from study to study, different types of neuropsychological tests are utilized. And as a result, a meta-analysis is not really possible. But of the studies that were available for review, the cognitive findings were somewhat variable. So Marino et al. Found that at 1 year, the patients who underwent an anterior temporal lobectomy ended up having decline in memory, and that was associated with the side that was resected. So patients who ended up having a left resection ended up declining in terms of verbal memory, and those who ended up having a right resection ended up declining in terms of nonverbal memory. Only a slight decline was observed in the patients who underwent a left selective approach, whereas those who actually ended up having a left selective amygdalohippocampectomy improved in cognition. Another study found that following a right anterior temporal lobectomy, again, they ended up having worse nonverbal memory scores than their counterparts. However, they found the opposite for the left side. So individuals who underwent a left selective approach ended up having worse verbal memory, as well as verbal IQ scores in comparison to those who had an anterior temporal lobectomy. And then Wendeling et al. Actually just found that overall this selective approach was better, and that there were better cognitive outcomes for visual encoding, verbal and visual memory, as well as visual working memory.
Michelle, you may have said this, but I'm curious, are there as many left versus right or dominant versus non-dominant procedures?
I believe it's roughly equivalent. Yeah, and I don't know if Dr. Miller knows any different, but I do believe that overall it's
They are.
roughly
People don't
equivalent.
steer clear.
I guess some people do, but overall no.
Thank you.
Mm-hmm.
For both the ATL and SAH surgeries, what is the percentage that have these cognitive problems? I mean, what percentage of people have something?
Have some sort of cognitive issue
After surgery.
after surgery. I think it depends on the patient and where they are premorbidly. So if they're premorbidly already pretty, if they've already declined quite a bit, they're less likely to have a decline, whereas individuals who have relatively intact functioning prior to the surgery are likely to have greater decline. So I think it really depends from patient to patient.
A couple of slides back, you had said that the morbidity of the temporal lobectomy was only 8%. Does that
Right.
include this? Would this be considered in that?
I don't
morbidity
think those
category?
really include cognitive effects. And one thing that we'll look at is, I don't know if it was part of that slide. So this slide shows that in the randomized control trial, they didn't include visual field deficits as really part of one of their surgical complications, whereas when we look at our data later, we actually do include it. So I think, from site to site, people include different things, and unfortunately, not all the studies list everything either, so it's hard to compare some of that data. All right. Okay. All right, so in terms of a laser ablation, this is a minimally invasive approach that we are starting to use here at the University of Washington, and it involves making a small incision in the skull and then inserting a tiny fiber that is guided via MRI to the amygdala and the hippocampus where they are ablated. And currently we have approximately 46 patients here at the University of Washington that have undergone this procedure, though I think probably in the last couple of weeks that number has increased. And so this is just visual of kind of what is being resected or ablated and how much is being resected and ablated. In terms of seizure outcomes, so Dr. Robert Gross at Emory has collected data from 130 patients, not just from the University of Washington and Emory, but from various institutions, and looked at their data at 12 months and found that in terms of seizure freedom, approximately 62% were seizure-free post-ablation. That percentage went up slightly in terms of individuals who did have some sort of identified hippocampal sclerosis or lesion, and that number dropped when there was no identified hippocampal sclerosis on imaging. And these results are actually pretty similar to what's in the literature for open resections. So like we talked about previously, in terms of seizure outcomes for open resections, that's generally in the 60s or sometimes in the upper 60s. And seizure freedom, again, does improve with an open resection when there's an identified hippocampal sclerosis. So this is really in the ballpark of open resections. In terms of perioperative complications, so this is looking at 46 patients who had a laser ablation here at the University of Washington and 49 at Emory. Perioperative morbidity was at 6.3%, and again, like I said earlier, we did include someone with a persistent visual field deficit in our numbers here. So we've had one small asymptomatic infarct, one subdural hematoma, 2 significant intraparenchymal hemorrhages without permanent deficits, and then also 1 temporary partial third nerve palsy.
How do you get that?
How do you get?
The third nerve.
I would not be the one to talk about it. Yeah.
Okay, well, I don't
Yeah. So, yeah, it's a good thing. And so This is actually possibly suggestive of better better numbers for in terms of perioperative morbidity, because in terms of the randomized control trials that have been performed, the numbers were generally around 10 to 33% that we looked at earlier.
Does the amygdala have to be involved?
In terms of?
Well, I mean, how important is the amygdala in the seizures?
I think,
Depends on the patient.
right, and so some of our patients, yeah, I think the amount that's resected depends on the patient and where we're seeing the seizures. So, all right. In terms of cognitive outcomes, we've looked at patients who have had an open resection versus those who have had a laser ablation. And each of these patients were administered the modified Iowa Famous Faces task. And again, this is the task that we discussed earlier, as well as the Boston naming test. And this is actually a standard procedure that's administered in most neuropsychological batteries. And this involves a two-dimensional black and white line drawing of pretty common objects. And so in terms of individual level observations, 82% of the individuals who underwent an open resection actually declined on one or both of these tasks. When we looked at the side of the resection separately, 95% of the individuals that had a left open resection declined on one or both of these tasks in terms of naming. And then when we looked at the right open resection, 65% of these individuals declined in terms of famous face recognition. However, of the 19 individuals that underwent a selective laser ablation, none of these patients actually declined on any of these tasks for naming or recognition. So in terms of group level analyses, the decline was significantly greater for those who underwent a left open resection in comparison to those who underwent a laser ablation on both naming famous faces and common nouns on the Boston naming test. And then the decline was significantly greater for non-dominant temporal lobe epilepsy patients who underwent an open resection versus a laser ablation for recognizing famous faces. All right. And so these are just a few of the different types of items that are administered. But what this data suggests is that naming and recognition can actually be spared for individuals who have drug-resistant temporal lobe epilepsy and are considering a surgical procedure if they undergo a selective laser ablation. It also suggests that the hippocampus is not an essential component of neural networks underlying name retrieval of famous faces or recognition of famous faces or common objects. And I think this is probably mislabeled, and it's not really preliminary data, but this is where we would like to go in the future. We want to look more at memory and how a laser ablation does affect memory. And we hypothesize that because it's assumed that the hippocampus is critical in terms of episodic memory, that there will be some sort of decline following a laser ablation. However, we're hypothesizing that that decline may not be as severe because we're sparing some of those other memory-related structures. So here I've just listed a few of the patients that I've seen clinically, and we can go through those and see how they do prior to the ablation and then post-ablation, a year out post-ablation. So the first patient ended up having a left ablation. This person had secondarily generalized seizures occurring once every approximately 2 months and did have left MTS. And one thing to note about this patient is that prior to surgery, this patient was already pretty impaired. And so you can see verbal memory and storing memory were already severely impaired, and figure memory or nonverbal memory was in the mildly impaired range. Post-operatively, those really didn't change much, again, with remained severely impaired in terms of verbal list memory and story memory, and figure memory was in the 5th percentile, but still in the mildly impaired range. And so in parentheses, I did put the raw scores so that we can take a look at those as well. At baseline, the patient on list memory recalled none of the words following a delay, but a year post-operatively recalled one of the words. And so if they recalled 0 post-operatively, you might say that you really don't know if there's been any significant change because they were already at floor levels, but because they were able to recall 1, you may say that maybe there wasn't as much of a decline. Story memory, they recalled 2 aspects of the story, and then post-operatively recalled 1 aspect of the story. Again, not a significant change. And then in terms of figure memory, previously recalled 11 aspects of these various figures, and then post-operatively recalled 12 different aspects of figures. So it doesn't look like there was really that much change in terms of this patient's memory. The next patient also had a left laser ablation. This patient had complex partial seizures weekly, and on imaging they had left amygdala increased flare. In terms of verbal memory, there was really no change, and that was for verbal list memory and story memory. But there was actually an improvement, and this was a significant improvement in terms of nonverbal memory. So it went from the mildly impaired range, the 8th percentile, to the 63rd percentile in the average range. And so that's kind of unusual given that the patient had a left laser ablation, but there are some people who believe that in terms of even nonverbal memory that there is a language component involved, because we're looking at shapes and we're identifying them verbally in our heads. You know, if you see a square or a triangle, and you're having to draw those later, so you're still using some verbal skills in terms of that. And so now that the patient is seizure-free, it may be that they improved, but really I don't know exactly what happened there. Next, we have a patient who had a right laser ablation. This person was having 30 to 50 complex partial seizures a month, so a lot of seizures. This person had possible right MTS, and they really improved on all memory measures, both verbal and visual memory, and I'm presuming this was due to the fact that now that they're seizure-free, and so their cognitive functioning as a whole just kind of improved. And then our last patient had right complex partial and simple partial seizures, having approximately 5 seizures per month. They had a possible right mesial temporal sclerosis, and also had a left frontocortical white matter lesion. And the data here was a little weird as well. So this patient ended up declining on a verbal list memory task, went from the average range to the mildly impaired range, whereas his other scores didn't significantly change. And so that's unusual, and I don't really quite know what's happening there either, and I think we need to do a lot more investigation, but it's possible list memory does have some, it's frontally mediated, can be frontally mediated as well, and so the frontal lobes may have been involved in that. Yes?
My question, were they able to take into account the medications that they were researching?
Yes. So in terms of medications, a lot of our patients aren't necessarily, the medications aren't changed a year out. So I don't think that would necessarily be a big influence in terms of the change here, unless I have some of that information correct. But most of the patients I see, really their medications haven't changed at year 1.
Not even the dose?
Usually,
We only change the medication the first year, and we start having toxicity.
yeah.
So only a very small number have toxicity.
So I think this data, I mean, I would say that even clinically in terms of the patients that I've seen that have a laser ablation and become seizure-free post-ablation, most of the time what we do see is that their cognition is relatively stable from their preoperative scores, or there are improvements, and presumably that is due to the fact that they're no longer having seizures. But I think a lot more research obviously needs to be done. Right. So in terms of laser ablations, there are obvious advantages and disadvantages, and this has some sort of implication for our clinical practice. So one of those advantages is that there's better cognitive outcomes specific to naming and recognition, and possibly in terms of memory. And so what this means is that if, in terms of seizure outcome, it's relatively similar to that of what we see in open resections, a laser ablation would be preferred. And this is particularly the case in patients who are undergoing, who have left temporal lobe epilepsy and have left language dominance. It would also be better for patients who have just overall higher risk for poor cognitive outcome following an anterior temporal lobectomy. But further studies do need to be performed. There is the other advantage is that there's possibly less perioperative morbidity as well, and this makes it more suitable for older patients and for those who have medical comorbidities. So we have actually done a laser ablation on a woman who is 78 years old, and she's 80 now. So she was 78, I think, at the time of her first ablation, and then she ended up having a redo because she continued to have seizures to ablate a little bit more of the amygdala, and she was 80 years old at the time. And post-ablation, she was spunky. She wanted to go hang out with friends, and yeah, so it may be better for individuals who are older. In terms of hospital stay, it is shorter, so most patients are monitored overnight and then discharged the next day, whereas patients who undergo a resection may be in the hospital for, on average, 2 to 5 days. So this results in lower cost, and so a comparative cost study should be performed as well. And just because a patient has had a laser ablation, this doesn't preclude them from having further surgery. And so, like I said, this 78-year-old woman who's now 80 ended up having a redo of the laser ablation, but if patients do not achieve seizure freedom post-ablation, they can go on to then having a resection as well. A laser ablation may also be more appealing to patients, particularly patients who have declined an anterior temporal lobectomy for various reasons. They may consider laser ablation. We actually had a patient who was having left temporal seizures and was offered anterior temporal lobectomy or a resection, and this was a while back. She declined because her verbal IQ was in the superior, very superior range, and she had a job that required her to be able to speak in public and utilize a lot of verbal skills. And so she declined. When she found out about the laser ablation, she came back and had asked about the laser ablation. She did go on to actually having a lesionectomy, but it is more appealing to individuals who fear having a temporal lobectomy. Another, well, it's an advantage or maybe a disadvantage is that the area that's ablated is restricted, it's small, and so there is the possibility of actually missing the area where the seizures are coming from. And so a laser ablation may only really be appropriate for individuals who have hippocampal sclerosis seen on neuroimaging, or those who have well-documented mesial temporal lobe epilepsy. And so a laser ablation cannot necessarily be more effective than a selective approach because they're essentially removing the same area of tissue, but it may be less effective than an anterior temporal lobectomy. And so where in situations where there's less cognitive risk and less surgical risk, anterior temporal lobectomy may be preferred. And so we may benefit from being able to look at some studies comparing a selective laser ablation approach to medical management because it may be more difficult to do that in terms of comparing to a temporal lobectomy. So in conclusion, what this data suggests is that selective laser ablation of the amygdala and hippocampus is an effective tool for treating drug-resistant temporal lobe epilepsy. And in terms of seizure outcome, it is relatively similar to what we see in open resections, and perioperative outcomes may be slightly better. And then also naming and recognition abilities and possibly memory functioning can be spared or reduced in terms of using a selective laser approach. Right. In terms of our primary collaborators, so Dr. Ojaman, who is a neurosurgeon here, and as well as Dr. Miller, who is the director of the Regional Epilepsy Center, and Dr. Grabowski, who is the director of the Memory and Brain Wellness Center, is involved in the research that we're doing, and Stephanie Malahan is our research coordinator. These are our colleagues at Emory, and then we also have other individuals working with us from Stanford and Oxford. Right. Any questions? Any questions?
And you need to minimize your screen there, Michelle. So
Okay.
Questions.
So if you click on that, roll as reading boxes.
All right. Yes.
So I wanted to follow up on Dr. Swanson's question,
Mm-hmm.
and that is, I get the feeling people are ignoring the amygdala, and I think so. Number one, is that true? And number two, I assume that's because it's not clear what the amygdala does, and it's difficult to test its function or loss of function. But a big hunk of it is being removed, just as much as the hippocampus.
Right,
One
right.
wonders what effect that's actually having on the patients, perhaps in terms of their emotional tone,
Right.
responses to anger and to emotions in other people. You know, there's these tests of looking at people's faces and deciding what's the emotional tone of this face I'm looking at.
Right.
Have you considered trying to pursue that at all?
I have not, but I think that is actually an interesting question, and we do have psychological measures in our test batteries, and that is something that we could possibly look at in the future. But I think you're right. That would be a really interesting thing to study. But currently we don't necessarily, in terms of actually having measures where patients are looking at facial expressions, and actually the research study that we're working on right now, we do have a test. It's an eyes test where patients look at eyes, and they have to determine what the individual is saying just by looking at eyes. So we could possibly look at that in the future.
And to pursue this even further, are there any neuropsychological test batteries or outcomes that you would use to say, oh, I think the amygdala might be involved?
There are, if you're trying to look at, so there are some older tests. I can't even come up with the name right now. It's from the WAIS-3, the picture completion, or not picture completion, picture arrangement. And so that one might be a test that we could utilize. We're not using that in our current research battery, but I do think the Baron-Cohen eyes test is one that we could actually use for that. And that is part of our research battery. It's not part of our neuropsychological test battery that we typically administer.
There are also a couple of tests with emotional memory, which recruits the amygdala a little bit more than neutral stories. So they're older also.
Right. So I may not have as much exposure to some of the tests that were utilized
I
previously.
felt a little discharge from my amygdala when you showed that picture of Hillary Clinton.
I can't comment on the neuropsychology of the amygdala field. I can comment a little bit about amygdala and epilepsy surgery. When I first started doing this, I worked for a while with Steve Goldring, who Bruce knows well. And his thing was that we should spare the amygdala in surgery because it is the bystander. That it's, you take out because it's there, it's right anterior to the thought that it probably was involved in epilepsy. Now that we have better imaging, we know that sometimes it is. And for example, there was a patient last year that we did ablation of the amygdala, and getting this plastic amygdala that we received it coming from. We also had a patient who we were trying to spare the amygdala and does ablation of the hippocampus, left the amygdala, and he had recurrent seizures, so he came back to him later. That they're neurologically very distinct structures in the brain. And I'm sure that there are many patients where the amygdala is not involved in the generation of seizures. And this method allows us easily to decide to spare it or not spare it.
What do you see after the laser surgery? Infarct?
A hole. In the hole.
You have a hole.
Modestly.
I think we actually consulted on Dr. Swanson. There was a patient we had that they had their VT shunt that they clogged, and the neurosurgeons went in to try and burn it, but the wire went through one of the holes, and then they burned some of her thalamus, and so she has a sort of a line where there's a black hole, and then around it, it had like diffusion weighted changes just right around that area where there was no injury. Yeah. Oh, was it with you? That big a thing? Okay. You guys were both on it.
Yikes.
I mean, I truly see one part of the spinal fluid, and you see later on you see neurosis and smaller than
So did they, was the amygdala removed in HM?
Oh, HM had big bilateral temporal
Right. So he had bilateral loss of his amygdala.
and his temporal cortex.
Right.
Temporal white
But
matter.
but emotionally, that didn't do much to him. Am I correct about that?
I think that emotionally he, if I remember correctly, did have some emotional changes too, but yeah. You can correct me if I'm wrong from the other neuropsychologists, but I believe that there were some changes in emotion in HM as well.
So is this, I mean, obviously, the side of the page with the advantages was pretty impressive. Do you see this sort of being the first thing now being considered?
Depends on the case.
Right.
Depends on the nature of the epilepsy.
Mm-hmm.
With some of the hippocampus sclerosis, it should be used most of the time. And this past year, half of our surgeries were with laser light. Wow. And it's the treatment of choice for hippocampal hypothalamic tumors. It's by far the easiest and best operation for that. And for patients with straightforward medial temporal epilepsy that you're sure of, especially if they have hippocampal sclerosis, it's a preferred method.
So then is none of the tissue available for pathologic assessment? If it's just ablated, you're not able to verify sclerosis?
We don't get tissue, but a lot of times temporal lobectomy is done without getting pathology. It's something many say. And I think we're living in the era where we have MRI. And a lot of times we get a better information on molecular pathology from MRI than actually from tissue examination. But anyway, for example, I think that we often see MRI area of dysplasia with this clear abnormality indicates that dysplasia is causing epilepsy. And it's resected and they're called column. They don't identify them as dysplasia. In terms of hippocampal sclerosis, if somebody has clear hippocampal sclerosis in MRI, they really don't need pathology to explain that. MRI is good enough to know for sure about that in most cases.
I was surprised by the surgical approach. It looks like you're taking the longest possible path to get to the amygdala. Couldn't you do it from the temporal area?
Yes. The reason for doing it this way is like a 3 millimeter hole in the back of the head.
Yeah.
And it's and the needle is put along the axis of the hippocampus. And that's the same with epilepsy with the hippocampus. And imagine that is approaching with the entire amygdala going past. That's the first advantage. The second advantage is it doesn't touch the temporal lobe. Unlike all the other procedures that Michelle was talking about, like selective amygdalohippocamectomy cuts through white matter, temporal white matter to get to the hippocampus. And we want to avoid that to avoid the cognitive problem we see with the stereotypical lobectomy. So by going from the posterior approach, you avoid any injury to any structure in the temporal lobe except the hippocampus and amygdala.
But you got an awful lot of territory with blood vessels in it and other kinds of things that you could pick off.
And that complicate the rate, indicate that that something happened. But, you know, it's done, the actual ablation itself.
Can't use GPS for that because it's going to take the shortest route every time.
But, you know, the ablation is done in real time. So the person inside the scanner, and you can actually look at the scan and see the temperature shift during the ablation itself, so you can control the size of the lesion. And the other thing about it is that blood vessels tend to carry away heat from the spinal fluid. So that tends to limit the lesion to the actual crack of my brain. But it's done in the MRI. The lesion itself, the heating in the brain is done in the MRI. So you can, you know, control the size of the lesion in real time.
Very good, Michelle. We know what to do now. It's kind of a problem. Thank you very much.